Okay. So this brief discussion is going to cover writing pediatric prescriptions, and it's a preparation for the Pediatrics 1 clerkship orientation, which you will be attending shortly. And after you view this, you should be better prepared in order to be able to know how to do this, and we can practice the skills during the orientation. The learning objectives for today's talk is for you to be able to describe how pediatric medication orders are different from adults in that they are dependent on their body weight, which is not always the case when you write an adult prescription. And it's also for you to be able to demonstrate how to write a pediatric prescription for both the inpatient and an outpatient during your clerkship. So a few things about the medications themselves. The medications are different not only because they're dosed on the child's weight, which needs to be in kilograms, but often that these medications are liquids. And these come in the form of elixirs or solutions that must include concentration instructions. And we'll talk about that in a little bit, but that's one major difference. The other issue that sometimes students don't recognize until they come to the pediatrics clerkship is that kids will spit out those meds that taste bad. And so sometimes your adherence to medication regimens can be affected by this, and we'll talk about how to overcome that if that is the case. You can sometimes crush pills and mix it with a syrup. So if the liquid formulation of a medication doesn't taste very good, you can sometimes get a pill crusher and take a pill and crush it and mix it with the syrups that the pharmacist sells, or you can get over the counter at grocery stores. This is an important topic because if you don't recognize that the math is important and you have to be very careful when you are figuring out the dosage and the concentration instructions, that this can lead to harm. And so this is an article from Contemporary Pediatrics in 2008 written by James Broslow, who is known for the Broslow tape in code carts for pediatrics, where he's trying to make it simple and based on the child's height, allow people in emergency situations to dose medications. So he is known for his work in the safety area in this. But I think one of the things that it's important to recognize is that the decimal points matter, and the fact that we are trying to prevent harm when we are giving medications to children, and that there are ways to do practices that you can follow that will allow you to become a safer prescription writer. So along those lines, this is a little test here. So is that a correct way, do you think, to write 0.2 milligrams if you were going to write 0.2 milligrams as your dose of a certain medication? Do you think that that is a correct way? And we'll go through this briefly here. And the answer is that it is a correct way to write 0.2. You always want to list or put a preceding zero when you are writing medication dosage, and that is to highlight the fact that there is a decimal point there. Is that a correct way to write 2.0 milligrams? If you were going to give a child a medication for 2 milligrams, do you think that that would be a correct way to write 2 milligrams? And the answer is no, it is not correct, and it's that you never should put a trailing zero when you are writing a medication dosage. You would just leave that off, because if someone missed that decimal point, if they were reading a handwritten prescription, they might interpret that to be 20 and give a 10-fold overdose rather than 2 milligrams. Is that a correct way, do you think, to write 5 milligrams? And based upon what I've just described, that is a correct way to write 5 milligrams if that is what you need for your dose. And is that a correct way, do you think, to write 0.5 milligrams if you need 0.5 milligrams of a dose? And the answer is no, that is not correct, and it's for the same reasons that this is correct up here. You always put a preceding zero and you never put a trailing zero. So other safety topics include abbreviations, which in general are the best case would be that you don't abbreviate when you can spell out. So we don't write QD anymore. We need to write daily, or you could write QDay. You should not write IU for international units. These come in the forms of vitamins, often 400 IUs of vitamin E. You should write out international or INT units. You should not abbreviate drug names. So if you need hydrochlorothiazide, you should write hydrochlorothiazide rather than HCTZ. If you would like micrograms as your dosage unit, write out micrograms or MCG rather than the μg. μg here can be interpreted as mg for milligrams, and that is a 1,000-fold overdose if someone interprets a μg to be a milligram. Okay, so if you're on the ward or anywhere, the proper process for writing medications is to list the name of the medication. The dose comes next, and for any child under 40 kilograms, there's a hospital requirement for you to specify that dosage equals how much milligrams per kilogram. And this is, again, a safety feature for children who are little, to be able to not only say how much you would like, but that is equal to how many milligrams per kilogram. So you need to know the child's weight in kilograms. Then after the dose, you write the route. So is it orally or IV or sub-Q that you're going to administer this? And then the frequency, how frequent. So daily would be once a day. BID would be twice a day. QID implies 4 times a day, and QOD would imply every other day, once every other day. There is a difference between, say, BID and Q12 hours, or QID and Q6 hours. There's one that's not written here, which is TID, which would be similar to Q8 hours. There is a difference, though, why you would choose to write QID for a medication rather than Q6 hours. And if you write QID, that implies that you would like the parent or the nurse to give the medication 4 times a day throughout a 24-hour period. Q6 hours implies that you would want that medicine in the child every 6 hours, and that would mean that you would need to wake the child up during the middle of the night, or no matter what is going on during the day. Every 6 hours the child gets a medication, versus QID, there's a little bit more flexibility there, and while you need to get 4 doses in to the child during the 24-hour period, you could do that on a schedule where the child is getting the medication breakfast, lunch, dinner, last dose for the day at bedtime, and then let the child sleep for say 10 or 11 hours at night, as often younger children do. So you would not have to be waking the child up, and that is what is important to recognize when you're writing medication in the hospital. You could, if you need it to be Q6 or Q8, you can write that and the nurse will administer that. But when you're writing an outpatient prescription, it's important to recognize that writing a Q6 frequency for an outpatient med is probably going to lead to not very good compliance, because it's hard to do that, wake a child up that many times. And also you probably only need it to be QID, and that is the major difference between those terms. If you want the medication to be in the child dosed and in the child being administered within 1 hour, you need to specify urgent. And that is important when you have children that have potentially life-threatening or very serious conditions that you need the medication quickly. The pharmacist will stop what they are doing downstairs once they get the medication order. They will put everything else aside. They will fill that medication and send it up to the floor. The nurse will then administer the medication, and within 1 hour of you writing the order. So you shouldn't do this if it's not necessary, but if you do need something quickly that is not accessible on the floor in the Pyxis, you should write urgent. Okay, so we have an example here, and this is where you're going to get a piece of paper out and do a little problem. So you have a 10-kilogram patient who's admitted for failure to thrive, so hasn't been eating as well and maybe has failed outpatient, increased caloric content, and is going to be admitted for failure to thrive, and see if can figure out why the child is not growing as expected. And you do a full exam, and you happen to see that the child has a right otitis media. And we'll set aside the fact that some people would suggest that older children with this condition, maybe 2 or 3 years old, may be able to watch and wait. We're going to take a 10-kilogram patient who probably is around a year of age, and we're going to treat that patient with antibiotics. And so you have a question about what medication do I give this patient and at what dose, and what's the route or the form that this comes in, and what frequency do I give it? So those are all good questions when you feel like you need to write a prescription. So those are the questions you should ask yourself. We have references that and evidence that show us that amoxicillin tastes very good, it's very well tolerated, and it's first-line antimicrobial therapy for acute otitis media. And you know this because you've gone to a pediatric dosage reference, and I've listed here Harriet Lane Handbook, and I've listed the page from the amoxicillin section. So once you figure out that you want to give amoxicillin, then you would look into a book. And my favorites are the Harriet Lane Handbook or the Pediatric Dosage Handbook. You can also use other products that are specifically for pediatrics, but I would caution you not to use drug books that are adult focused, because they are invariably going to mislead you about what is the proper dosage for children. So when you look in the amoxicillin section of Harriet Lane, what you find is that you have the name of the medication, but you also can look down here and where it gives you the information about how you dose this in a child. It'll say a child dosage is here. It does give the adult dosing, but for this child, this 10-kilogram child, you're going to be looking at the child dosing. And it tells you that this amoxicillin is dosed between 20 and 50 milligrams per kilogram per 24 hours, and that this is divided TID, and it's taken orally. This is an oral medication. But if you read further here, and this is where it gets a little bit confusing for people who are less experienced writing pediatric prescriptions, is that it gives you the maximum dosage at 2 to 3 grams per 24 hours. It tells you about the indications, what dosage you would give for recurrent otitis media prophylaxis, which is not what we're going to be doing. That's a once-a-day dose at bedtime. QHS implies that you want to give that at bedtime. Endocarditis prophylaxis would be seeing another page. It gives you renal elimination information, so that's what this icon up here shows you, is that it's eliminated in the kidneys and that you need to adjust it and adjust your dose in renal failure. It tells you a little bit about the side effects, rash and diarrhea. And then there's a section down here that says higher doses of 75 to 90 milligrams per kilogram per 24 hours. Divided TID taken orally have been recommended for resistant strains of strep pneumoniae in acute otitis media, and that is actually where we would want to dose this child. So you might be misled if you were just going to where the initial information here has about how to dose this. So it's important to really understand the medication and read about your patient and where the dosage range should be for this for the thing that you are treating. And this is called high dose amox, and we do this all the time. And this would be considered to be an underdose of this acute otitis media. It does also list some information at the top here that gives other names of the medication. It tells you it's an antibiotic and it's an aminopenicillin, and it will come in different forms. So it comes as drops, as 50 milligrams per mil. It comes in a suspension, which is what we would likely be using. We don't need infant drops, but suspensions come in either 125 or 250 milligrams per 5 mLs. And it tells you here that these are the amounts that it would come in. You could put in a bottle, but the more important thing here is this is the concentration instruction. It comes as 250 milligrams per 5 mLs. So when the parent or you are dosing this medication, every time you give 5 mLs, you are giving a 250 milligram dose. Or you can get a different dose, the different suspension that has 125. They also have other concentrations available now, 400 milligrams per 5 and 600 milligrams per 5 mL. So those are other options. But this is why it's important, if you only specify a milliliter, a certain volume without specifying the concentration instructions indicating how many milligrams per milliliter or per 5 milliliters in this case, then you could be giving a wildly different dose to your patient. It also comes as capsules, 250 or 500 milligram capsules, or it also comes as chew tabs. But for our patient, we're going to be giving a suspension. So let's write the prescription. And so what I want you to do is get out a piece of paper, you stop the video for a few minutes and get out your calculator, and you have a 10 kilogram patient and that you want to dose this medication. And again, Harriet Lane shows you that it's 75 to 90 milligrams per kilogram per day, and that's divided TID. So stop the video and write the prescription. Okay, so the answer, if you work out the math, could be that you write amoxicillin suspension 300 milligrams POTID, and then you have to specify, since this is a patient under 40 kilograms, that you have to specify the milligrams per kilogram and that you're dosing it at. Now, you might ask, if you got a different number up here than 300, why this is a correct answer. If you got something a little bit lower than that. And the way that I figured this was, if you have a 10 kilogram patient and you dose the medication at 90 milligrams per kilogram per day, that's a total daily dose, then the total daily dose would be 900 milligrams. And that's easily divided TID, which is what the standard frequency of this medication is. So the math is easier when you divide 900 by 3, you get 300. If you divide something less than 900, if you chose 80 milligrams per kilogram per day and you multiply that times 10, you get 800. And dividing 800 by 3 is harder, and dividing 750 milligrams by 3, it may be, the math may not be hard. It's 250, but the point here being is that you want to try to make the math as easy as you can. And so while you would not be correct, or you would not be incorrect to write the prescription as 250 milligrams POTID, which would get you to 75 milligrams per kilogram per day, we usually dose this a little bit on that higher range between the 75 and 90. So that is why this would be what I would prefer to be as the answer for this. Now, when you are writing that same medication for discharge, there's just a few differences. One is that while on the prescription, and often this is done in your electronic medical record, but you'd want to list the date and the weight. But in this here, instead of saying amoxicillin suspension, you could list amoxicillin and then the exact concentration instruction that you are asking the pharmacist to provide. So instead of just giving the pharmacist information that you want a liquid, you could say that you want this particular concentration instruction. And then you have to write a signature line. That is what the pharmacist will print on the bottle, the liquid bottle, for the parent. And so if we want 300 milligrams for this patient and the concentration comes as 250 milligrams per 5 mLs, then for each 1 ml of this medication, there is 50 milligrams per 1 ml. So if you need 300 milligrams as your dose, then the math works to be you give 1 more milliliter than what is in this concentration. So you would give 600 milliliters, 6 milliliters POTID times 10 days, and this is the duration that you would typically treat an otitis media. You would list the quantity, and here I've just listed 200, and that number comes from doing math where you say that you need 6 mLs 3 times a day, which is 18 milliliters a day, and you need it for 10 days, so that's 180 milliliters total, and rounding up just a little bit to give the parent a little bit more in the bottle in case the patient spits it out or that there's spillage of that. You can do that. You could also write quantity sufficient times 10 days and let the pharmacist decide how much extra they're going to give in terms of the liquid. It's important to note that pharmacists will not provide extra pills. So if you write a prescription where instead of a concentration here, because you're going to give a chew tab or a pill or a capsule, they'll give you the exact number of capsules or pills that you have requested. You would want to make sure you list the refills, none. This is again for discharge, so in the inpatient medication you wouldn't have to necessarily specify how long you were going to treat. You could write just the prescription and then stop it when you were ready to stop it if that was your intention. And you don't obviously need to have refills in the inpatient environment. You would sign it. The other way, just to say to make this even more complete, would be that you could write the same prescription for discharge as amoxicillin, 250 milligrams per 5 mLs, and then the signature becomes 300 milligrams, which is 6 mLs in parentheses, so everyone can do your math with you, POTID times 10 days, and that would also be acceptable. All right, for on the ward, if you were going to give an IV medication, we're going to practice that a little bit with a case where you have a 4-week-old 5-kilogram patient who comes to clinic and has a fever and you cannot find a source and you are concerned for a serious bacterial infection. We see this all the time, and we commonly work these children up for urine infections and blood infections and meningitis. So this is called a rule-out sepsis workup, where the baby is coming into clinic and a doctor will initiate taking samples from the bodily fluids, blood, urine, and CSF, and those cultures, we're going to assume that this culture workup was taken in clinic, so they've done all of the evaluation and data gathering, but they would like you to give empiric antibiotics once the child gets to the floor, once they're being admitted. So when you look under this discussion, often medication is offered with ampicillin and gentamicin, and those two antibiotics are chosen based upon the most likely organisms in these babies that have fevers. And we're not going to get into that as a discussion. This is about prescription writing, so we'll leave that for another day. The ampicillin, when you look in your pediatric dosage handbook or Harriet Lane or some other similar pediatric drug reference, you'll see that when you are treating a serious bacterial infection empirically, ampicillin is dosed 200 milligrams per kilogram per day, and it's divided Q6. And here is the situation where you would want to give that medicine every 6 hours. You are potentially treating a life-threatening illness. So again, Q6 rather than QID. When you look under gentamicin, you'll see that for a serious bacterial infection, empiric treatment, you would dose that at 7.5 milligrams per kilogram per day, divided Q8 hours. So again, get out your calculator and a piece of paper, and let's practice. This patient weighs 5 kilograms, and we want you to write these orders for both ampicillin and gentamicin, how you would do that. So stop the video at this point and then resume when you are done. Okay, so ampicillin, I'll start with that. So we said that it's dosed 200 milligrams per kilogram per day, and you have a 5-kilogram baby, so that is equal to 1,000 milligrams per day, and that's the total daily dose. And we said that it was divided into Q6-hour dosing, which means that you divide the daily dose by 4. And this is one of the areas that leads to math errors a lot. If people see Q6 hours, they sometimes divide the daily dose by 6. And get confused. So remember, Q6 hours in a 24-hour day, you need to divide it by 4. So you take 1,000 milligrams per day and divide by 4, and you get 250 milligrams every 6 hours. And this is an IV med. So your final prescription order should have been ampicillin 250 milligrams, IV is the route, Q6 hours. And again, you must specify that the first dose should be urgent, and this will again prioritize this medication for this baby. For gentamicin, we said that this dosage amount was 7.5 milligrams per kilogram per day, and you have a 5-kilogram baby, and that math, if you multiply that, works out to 37.5 milligrams per day. That's again a total daily dose, so you need to divide for Q8-hour dosing, you need to divide that dose by 3 in order to get what you were going to give each dose, and so 37.5 divided by 3 is equal to 12.5 milligrams, and that is the dosage amount. So your final prescription would read gentamicin 12.5 milligrams IV Q8 hours, and again, first dose urgent. And the other thing that you'd have to remember with this aminoglycoside is that we need to monitor drug levels to make sure that the baby is getting appropriate amounts and that you're not overdosing or underdosing. And so we typically will get a trough around the 3rd dose prior to either the 3rd dose or the fourth dose in order to make sure that the baby is getting appropriate levels. So, pediatric medications are dosed based on the weight, and that's an important concept. If you don't have the baby's weight or the child's weight, it's going to be impossible to write a prescription correctly. And so, compared to the adult medicine rotations, where sometimes you would, most likely, I would suspect that you are going to go into your dosage handbook and you're going to find the dose that you give for both, 100-pound people and 200-pound people, that sometimes that's an adequate way to write a prescription for an adult. In kids, that is not the correct way. Liquids will need concentration instructions always. If you are going to prescribe a liquid, you should do this, and this is especially important for a discharge prescription, so that you tell everybody the concentration that you want. And this is important from a safety aspect because unfortunately the drug manufacturers that make the same drug but different manufacturers have sometimes different concentrations. So one manufacturer makes this medication at 100 milligrams per 5 mLs, and the same exact medication by a different manufacturer is 10 milligrams per mil. And so those are very different in terms of if you just specify the volume in milliliters, you're not going to be able to understand how much milligram or the dosage that you need. Kids will spit out meds that taste bad, and that's important to remember. It's always important to remember the structure of name, dose, route, and frequency. And what I didn't say, but what I've implied along the way, is that this is a safety issue that we can definitely prevent errors where we kill greater than 7,000 people a year by doing this incorrectly. And so it's important to, as the old adage is, measure twice and cut once, is that you thoughtfully provide what you would be a prescription for medication, and then double check your math and maybe even run it by someone else as you are learning how to do this skill, to make sure that your order is accurate and correct. So if you have questions, we're going to talk about it at orientation, and we'll have more practice problems for you to do. So I will see you then. Thanks.